All right.
Ooh, Jinx, welcome to the show. Here with Dr. Katie Dolbec. We're gonna talk about some interesting topics. So what we're gonna talk about, and I'll start by saying we definitely immobilize bones that are fractured, but when else should we be immobilizing things in ED? What joints should we be immobilizing? I think that's sort of the gist of what we're gonna talk about today. What do you think about that?
Yeah, that sounds right. And I think maybe even more so, when are we hurting somebody with an immobilization? You're right. The fractures, the dislocations, those are no-brainers. We were trained to do that. We know to immobilize those. But then when someone doesn't have a break or it's not dislocated, well, now then what do we do? Do we put them in a brace? Do we splint them? They're going to see someone else in a couple of weeks. That'll help prevent maybe some further damage, but actually, are we actually causing further damage by putting people in splints or braces sometimes?
I love that. So yeah, let's run through some common joints and talk about when we should be immobilizing or when we maybe shouldn't be immobilizing. So I'll let you start
Great.
it off.
Yeah. So perhaps the one I have the most passion for is the knee. I remember as a resident, anyone with a knee injury got thrown in a knee immobilizer and given crutches. The thought was, it's not broken, it's not dislocated, but there's got to be some kind of soft tissue damage. And if we let them move it and we let them weight bear, then for sure they're going to cause more damage to that. So why don't we help protect them by putting them in a knee immobilizer and making sure that that knee doesn't bend, and then they won't do any more harm, and then they'll go to orthopedics in a couple of weeks and they can get more definitive imaging or more definitive examination at that time, and they can decide whether to take them out or not. As I went through fellowship, I learned a bit more about the harms of immobilizing joints in general, but maybe the knee more than most. So um, the knee tends to get really stiff. So when it's braced in extension, it tends to lose flexion pretty quickly. The other thing that maybe we don't know quite so much about is that there is some pretty good literature out there that the atrophy and loss of muscle strength starts to kick in a couple of days after mobilization. The other thing that maybe emergency physicians aren't quite so familiar with is the fact that losses in knee or in thigh strength and hamstring strength, quadriceps, and even calf muscles can actually lead to destabilization of the knee joint. So the knee joint is really well supported by the muscles of the quadriceps and the hamstrings. And by any kind of atrophy or loss in strength in those muscle groups, that will inherently cause more instability in the joint down the road if there is a soft tissue injury. So within a couple of days of being in that knee immobilizer, the patient is going to be stiff and they're going to be getting progressively weaker really quite quickly.
Sounds like immobilizing the knee is not a benign thing. So if we're going to do it, we should do it for a good reason.
Yeah, exactly. So we got to be thoughtful about who we immobilize in a knee immobilizer. And I have a few indications where I think it is probably genuinely indicated and we should be doing it. So there are some obvious ones. A knee dislocation. I'm not talking patellar dislocation, but a true knee dislocation. Of course, those folks should go in a knee immobilizer. And honestly, they're probably not going home. They're probably going to be in the hospital until they get some initial surgery, or at least an ortho eval. But that's a very unstable knee, and that's one that should go in an immobilizer to help support it, and perhaps even a long leg cast in conversation with ortho. Um, some posterior hip dislocations, and that seems a little bit backwards. You think, why would you immobilize a knee for hip dislocation? But the idea is that when a patient flexes at the hip and the knee, oftentimes, especially a prosthetic hip, is inclined to pop out backwards. So by placing that patient in it who just suffered a hip dislocation, again, particularly a prosthetic hip dislocation, in a knee immobilizer post reduction, the idea is that you're going to send them home, limiting their ability to flex at the knee and the hip simultaneously, which is going to decrease the odds of redislocation as things in the capsule are healing. And then anything in the extensor mechanism should be immobilized. So if you have a quadriceps tendon rupture, a patellar fracture, a patellar tendon rupture, or a patellar dislocation, so a kneecap dislocation, those should all also be placed in a knee immobilizer. And that's because if the extensor mechanism is broken, you want to help augment extension. So anything in that extensor mechanism should also have an immobilized replaced. Um, I don't think we have great data on what to do with displaced tibial plateau fractures, to be honest. And so I am sort of at a coin flip about that. I don't think in particular that people are going to do a whole lot more damage to that joint by ambulating on it or by flexing it. But it does seem logical if there's an intra-articular step off or a bad tibial plateau fracture that perhaps is awaiting surgical repair, that it's reasonable to immobilize that to prevent, in fact, further damage to the joint.
And when we're talking about immobilization, there's sort of two ways I can think about immobilizing. One is to actually splint the thing, the other, or cast it, and the other is to put those knee immobilizer, Velcro things that we have. Are you talking either or for this?
Yeah, I am talking either or. I think it's often easier for us to put them in one of the fabricated Velcro splints. I think they're a little more comfortable. It allows the patient potentially to remove it to bathe, which I think is always humane. But depending on where you're working, resources available, whether or not you have those available to you, maybe you're working in a resource poor area and you need to actually just place someone in a more definitive splint, that would be acceptable as well. There are also those hinged knee braces. I don't want to confuse anybody with those. Those are ones where they have the supports on the medial and lateral sides and you're allowed to flex and extend. I don't think that those braces are going to be sufficient for the injuries I've outlined, which again are anything in the extensor mechanism, a posterior hip dislocation that's now been reduced, a knee dislocation, or possibly a displaced tibial plateau fracture.
Okay. All right. So I guess that leaves a lot where we shouldn't be.
Yeah.
Putting the immobilizer on that. I think a lot of us do, where we suspect an ACL tear or a MCL or PCL, any of that stuff where we're seeing joint laxity.
Yep. Joint laxity or suspected meniscal injury is another one that I think people commonly think, oh, well, if I place them in extension, then that meniscal injury won't get worse until they see ortho. But I think those are the exact injuries that I'm talking about. I think those are the ones where actually mobilizing, maintaining strength, maintaining range of motion for those patients as they wait for formal physical therapy and ortho eval is going to actually be beneficial. And many of those folks won't end up with surgery and they will then be ahead in terms of their recovery.
So then would you recommend that they just sort of go with like a cane or just weight bearing accelerated, or what would you do with those patients then?
Yeah, so I will often with those folks start doing some retraining of, like I alluded to before, of using those big muscles of the thigh to actually stabilize the knee joint when they walk. So I will actually have them practice while they're sitting in the stretcher, contracting the quadriceps muscles, contracting the hamstrings muscles, and then actually seeing if they can contract them simultaneously, called co-contraction. If they can do that in the stretcher, then I ask them to try that while they bear weight. So they place the injured knee or the injured extremity down, the kind of toe touch. They practice contracting all those muscles, and then they take the step while those muscles are contracted, and that will support the knee joint. If they are not able to do that, I think it is fine to send them home with crutches and tell them to weight bear as tolerated. So to use them until they are able to weight bear without a limp, and then they can get rid of the crutches.
Oh, so they can still get crutches, but they don't need to be immobilized. Oh, I love that. Okay. Yeah. That's such a great pearl that I never knew before. So what else do you got for me?
All right, cool. So I think there are some other injuries that we also immobilize that perhaps we overdo a little bit. And I don't feel strongly about them as the knee. But there's actually perhaps better data on the ankle and the harms of immobilizing low ankle sprains. So most ankle sprains do better with early mobilization and weight bearing. And so historically, again, not broken, not dislocated, why don't we splint it so that they get better faster, while well-meaning, probably also leads to some harm. So low ankle sprains, so ATFL, PTFL, CFL, lateral ankle sprains, those can probably also similarly be placed in crutches, but not braced in any way. If they really want an ACE wrap to provide some compression and support, I guess so. But that's just for comfort. Any kind of a compressive sleeve brace is fine, but I wouldn't put them in those lace-up ankle splints. I wouldn't put them in one of the air splints. I certainly wouldn't put them in a plaster or fiberglass splint. or a walking boot. I would allow them to weight bear as they can with crutches, and again, wean off the crutches as they're able. High ankle sprains, so ankle sprains that traverse up the syndesmosis, those probably will do better from a boot. So that is one where you would. Any kind of unstable fracture or dislocation, again, not surprisingly,
Sure.
should be immobilized in a splint. And then some people think, well, man, what about a Jones fracture or a like Lees Frank fracture? Shouldn't those be placed in or I guess a Lees Frank sprain? Lees Frank fracture probably should get a full splint, but a Lees Frank sprain of the foot, a lot of those can do really well in just one of those stiff-soled shoes or post-op shoes and don't need the full walking boot. And again, you may end up harming that person a little bit by causing stiffness and weakness that you didn't intend to do.
So can you tell me a little bit more about distinguishing between a low ankle sprain
Ah.
and a high ankle sprain? Because that is confusing to me.
So glad you asked. Yes, absolutely. So low ankles, both of them actually can be caused by that traditional inversion injury. Those are the most common mechanisms. When you do an inversion injury, the lowest energy of the mechanism will travel through the three ligaments of the lateral ankle that connect the lateral malleolus essentially to the bones of the ankle. Those are the ATFL, the CFL, and the PTFL as you sort of march around the lateral malleolus. If it's isolated to those ligaments and they're tender there and there's no fractures, those folks should be mobilized as they can in weight bearing as early as possible. If the injury is higher energy, what's going to happen is it's going to kind of travel through those ligaments and it's going to travel to the distal, essentially tibial fibular ligaments, and then up the syndesmosis. And so if that syndesmosis has been pulled on, those don't do quite as well with weight bearing. Now, I'm not talking about the Maisonneuve fractures where they've actually disrupted the entirety of the deltoid ligament medially. The energy's traveled all the way up to syndesmosis and come out at the proximal fibula. Those are surgical. Those are going to immobilize completely. But the sprain of those ligaments, that syndesmosis, is the ones where I'm thinking, boot would probably be of some benefit. And the test that I do for that, yeah, is actually exactly what you're saying, is the tib fib compression testing. So
Okay.
I will squeeze somewhere in the proximal to middle third of the leg, medial and laterally, and I'll say, does that hurt? And they'll say, yes. And I'll say, okay, where? And they say, down at the front of my ankle. So not where you're actually pressing, but actually distal to that. And that makes me think that they have an injury of that syndesmosis. And I would immobilize them in at least a walking boot. I'm not sure that they need a full splint, but if that's what's available to you, that's okay too.
Okay, love that. All right, that made a lot of sense for the ankle and a little bit of the foot there that you mentioned too.
Awesome. You're right for a wrist conversation?
Yeah, let's do wrist.
All right. So I think some of these are for the wrist that I think we over immobilize are the pediatric injuries. So I will defer a little bit to your local orthopedic preference because pediatrics always gets a little bit dicey in terms of wanting to err on the side of caution. And I will note too that kids regain range of motion and strength in amazing ways that we adults do not. But I do think there are some injuries that we can probably be a little bit more lenient than we have in the past very safely. So one that comes to mind is the buccal fracture of the distal radius. So that little, and maybe the ulna too. So you've got that little tiny outpouching of the cortex, but no true cortical disruption. Those are very stable injuries. Very rare that those need any kind of reduction. They tend to remold really well. And so generally you're not going to make that bone's not going to move around a lot. They're going to be sore, but probably a couple of weeks in a Velcro splint is probably sufficient. And certainly you could have them keep it on until they see someone in follow-up. But I don't think in general that those are going to require a rigid splint that cannot be removed for a couple of weeks. I think it could be removed for bathing really safely without causing more harm to that injury.
Okay.
Yeah.
And that's specifically for peds where they're getting these potentially buckle fractures.
Yeah, that's
Okay.
a good point. Yeah, exactly. It's where the cortex is really plastic still and it sort of bends instead of breaking like it does in adults. Those traditionally taught, those non-displaced Salter 1 fractures, right? The Salter Harris fractures where you're maybe tender over a growth plate, but there's no disruption of the growth plate. There's no fracture above or below it. There's no displacement of the distal fragment. And you think, well, they're tender over the growth plate, so maybe they have a non-displaced Salter-Harris 1 fracture. I would also argue that those people probably, of the wrist specifically, could probably go in a wrist splint, Velcro, one that can be removed to bathe and wash hands, and then be followed up in a couple of weeks for repeat imaging. And I think that would be really appropriate. And then for the adults or the kids, those maybe they have a non-displaced scaphoid fracture, what we always worry so much about. And I think what we worry about is not that we fail to immobilize them, but rather that we are going to miss them altogether and they're never going to seek follow-up and they're going to have this non-union months to years down the road that we will have missed. So I think the key thing for a suspected scaphoid or a question of a scaphoid is just to ensure that they have follow-up. I think exactly how you immobilize them is much less important. So I think if that's someone who you trust to put in a Velcro splint, they could get one of those if you trust them to follow up. And I think, again, it's not the immobilization that's going to make the difference about whether or not this bone heals. It's really just making sure that they're following up with someone to ensure that it does.
Interesting. Okay. You would immobilize it in some way, but you're saying maybe it could be a removable splint.
Yeah, I would immobilize it for comfort, primarily, to be honest, just if they're having pain there. And if it's non-displaced and it's going to displace, it's nice to have some kind of immobilization. I think it's fairly rare that they actually displace. And then a podcast for a different time. But there is a little bit of literature suggesting that actually, if we are able to obtain MRIs on these patients from the ED, that there will be a cost savings to the patient and the system down the road if we are able to rule out a scaphoid fracture on MRI on the initial visit. Again, a topic for another day. But it is pretty interesting. So I think it just was a good reminder that the follow-up appointments can be a bit cumbersome, but they are the most important if you have any suspicion for a non-displaced scaphoid that you're missing radiographically in the ED.
Awesome. That was super, super useful for the wrist.
All right. One more, which is the elbow. I think I think this has percolated through emergency medicine pretty well. I think most people understand the risks of immobilizing the elbow and that they get stiff. There are a lot of things where we can't avoid immobilizing the elbow, and sometimes the elbow gets roped in as an innocent bystander for like a shoulder injury, for example, or using a sling for a splint of the distal radius just to support the arm for the patient. And I think sometimes that's unavoidable. But reminding people who do not have injured elbows to come out of that sling frequently and to move it is really important. Injuries where we actually wouldn't recommend generally placing a splint that goes over the elbow. So sling notwithstanding, there's definitely the mantra of you want to immobilize a joint above and a joint below a fracture. And so I think the traditional teaching has been if you have a distal radius fracture, you should immobilize the elbow because that's the joint above. However, I would say increasingly orthopedics is not immobilizing the elbow as part of that. They are doing a dorsal and a volar slab splint, not a sugar tong for the most part. And I think the thought process there is that they're not seeing those distal radiuses displace again, even while people are pronating and supinating at the elbow.
Oh, interesting. Yeah, I always wonder about that.
Yeah, and I think we've traditionally done it and thought it's okay. In a couple of weeks, they'll see ortho and they can take the splint down to, they can create a cast that's just a short arm at that point. But by then, there's a lot of stiffness of the elbow, and so I would definitely say that for most patients with a distal radius fracture, the splint should stop short of the radial head, which brings me to the radial head. If a patient has a radial head fracture, those can actually be in a sling with early mobilization. If it's badly displaced, then perhaps that's not quite true. But for the minimally displaced radial head fractures, those can be placed in a sling with mobilization ASAP. We do not need to put them in a long arm splint to wait to see ortho for a couple of weeks.
So when you say mobilization for the elbow, it's not like they should be doing like push-ups or something like that, but you're just saying to sort of
using it early though, definitely. Maybe not weight bearing a ton, but using it flexing, extending it, carrying things, all of that is okay.
Interesting.
The
Okay.
times when you would still want to immobilize the elbow, just to be clear, this is not a never. Supracondylar fractures, certainly you want to immobilize the elbow. A lot of those are also surgical. Um, if you have an olecranon fracture, so a displaced olecranon fracture, which also would really suggest a very unstable elbow joint, those should be immobilized as well. If there's a true elbow dislocation, those should also be immobilized after. A Galeazzi or a Montesia fracture, those are the ones that involve both the distal radius and the proximal radius or ulna, or distal radius and ulna, proximal radius and ulna, anywhere in that ring, forearm ring where there's two breaks in that, that's somewhere that you would want to do.
They're
True,
usually going to be getting surgery anyway.
you're going to get surgery anyway. Exactly.
Well, that's very interesting. I mean, it's cool to think about, places where we can pull back on the immobilization, and these are some great high yield examples here. I'm just curious, do you have anything for the shoulder at all? Because I know I'm always afraid of adhesive
Yeah.
capsulitis of the shoulder.
Yeah, such a good point. So I am still placing, I'm not doing really much in the way of clamshell or coaptation splints at all for the shoulder. I would say for shoulder dislocations, for clavicle fractures, for AC joint disruptions, I am still placing people in slings. But what I tell them is in the next 2 to 3 days, when you feel up for it, you should come out of that sling and start those pendulum exercises, which is where you kind of flex at the waist and hang that arm down toward the ground and use your body swaying to sort of gently move that humerus in the glenoid fossa. And that will help early mobilization of that joint to help prevent the adhesive capsulitis. Um, the caveat there is I do tell them to come out of the sling immediately every day, at least several times a day to move the elbow. But the shoulder, I tell them start doing those pendulum exercises, in the next few days whenever you feel like you really can.
Awesome. This is super helpful. So many little pearls in there.
Cool. Glad to help.